Hi, it's Matthew Hall with another THCB Spotlight. I'm here with a part of the crack team from Avasure. Is it Avasure or Avasure? Avasure.
Lava.
Sorry?
Ava like lava.
Ava like
Land, Ava
Ava,
shore.
Avasure or Lavashore without the L. Okay. I have with me Lisbeth Vortruba, who is the Chief Clinical Officer, and Dana Peco, who is the AVP of Clinical Informatics. Did I get those right? Brilliant. Thanks, ladies. Appreciate you joining me here. So the obvious thing is, if you have been in a hospital, you've probably been captured by Avasure, but you may not know what the company does. So, Elizabeth, what does Avasure do?
Um, yeah, thanks. Avasure is an intelligent virtual care platform. And what we do is we blend virtual care in patient interactions, but it's across the continuum of care in different healthcare settings, from acute care to long-term care, and then ICU, and even into hospital at home. And to do that in 2025, you must be AI enabled and you must be fully integrated. So we focus a lot on that. And then what we're really fundamentally, our goal is to improve the care team experience, because I'm a third generation nurse, and Dana is second, third generation nurse as well.
Third
Yeah.
as well. Yep.
Yeah. And we know, both of us know, that if the care team experience is elevated, the patient experience is elevated. And if the care team experience is poor, the patient experience is poor. So that's our focus. And it's virtual care fundamentally.
So there's lots of flavors of virtual care, and yours is one obviously that is in facilities and is integrated with the on the ground or on the floor staff, exactly what
Yes.
you're helping them. What has been the problem for hospitals? I mean, I would say, labor shortage is number one, and getting nurse staffing and the rest of it together is obviously a big problem. But what is the fundamental problem that you are helping hospitals and care facilities solve?
I would say labor is number one, two, and three.
Okay.
so so yeah, we help on staffing efficiency in a couple of ways. The one where our starting point was on virtual sitting, where instead of having one staff member to one patient when there's a safety issue, in you can have a 1 to 12 with a virtual, or 16 or more with a virtual application. And that's kind of the origins of our company 15 years ago. And but also virtual nursing, where a virtual nurse, a more experienced nurse, can support bedside nurses doing some of the documentation and patient education. Specialty consults, which is really especially pertinent for rural settings right now, where there might be an urban center that has great specialists and neurologists, and nephrologists is another big one. And then they can support their more critical access or community hospitals that keeps the right patient in the right place. And then all at that same time consolidating a platform that can be integrated, and so you're not having these individual little niche use cases and 10 different cameras in every patient room.
Yeah, and I'd say that fundamentally, one thing you didn't say is that fundamentally it doesn't matter how many humans you have, and yes, you could potentially have a human sitting in every patient room, doing the virtual sitting, doing the actual sitting if you wanted to, and deal with the costs of that. Even if you can find those people, which obviously it's very tough. But you didn't mention that even in a hospital room or even a facility, it's very hard to have 24/7 accurate awake eyes on the patient at all times. It's just, it's something that traditionally, I don't know how many go back 10 years ago, wasn't even thought of.
Yeah.
That now you can do that. And that's actually an improvement in the quality and the overall quality of care as something that, can be done using technology. Obviously, you mentioned a lot of other things, and obviously there is a staffing shortage, et cetera, et cetera. But it strikes me that that's kind of a fundamental change in how, I hate to say that when you two were training as nurses, might imply that that was more than 10 years ago, which I
It
certainly
was
wouldn't
more
want to
than
do.
10 years ago.
Wouldn't want to do, but I suspect that there probably wasn't a lot of this when you were in nursing school, and it's probably a big change in how people think now about how to deliver care 24/7 within a facility.
Yeah, but I'm going to challenge your tenure. We've been doing this since 2009, so more like 16 years that we've been doing that 24/7, eyes in the patient room. But back then, it was only 40 really innovative health systems that were doing it, and now we're in 1,100.
Right, so things have changed a bit. So look, why don't we? So for people who haven't seen this, let's take a look at what it means. Dana, I think you've got a thing you can bring up. So first things first, what does this look like in a hospital room?
Well, I'm glad you asked, Matthew. Let me show you what it looks like and what the patient experience is.
All right. You have a very good-looking patient there.
I do. That's our handsome patient. That's in Belmont, Michigan, our headquarters.
So just because this is a fake hospital room, not a real.
This is a fake hospital.
Well, certainly a fake patient. I'll give you that.
Yes, both, but it does have real hospital equipment, so that way you can get the feel of what it feels like.
Yeah.
And as you see here in this hospital room, we do have our 3 devices that we do deploy. You can see it in my bottom right of my screen. We do have flexibility in what you can install in your hospital. So as you can see here, where we started a mobile device. So you roll the device into the room. It doesn't mean that you have to take the patient to a different room. I can just roll it in, plug it in. It is wireless, so I can have my virtual encounter, or I can have that constant observation with that patient. Our other 2 devices, as you can see here, this one in the upper right-hand corner, that's a ceiling device, so it's up and out of the way. It's mounted into the ceiling. It can be mounted into a hard lid ceiling for ligature-free for behavioral health, and those environments that are meant to be for safe rooms, because we want to make sure that those patients are safe. And then lastly, our 3rd device, which is right here, that's attached to the television. What makes this device really unique is it actually has 2 cameras built into it. All of our devices are equipped with both cameras, microphones, and speakers. So you're not installing multiple devices in your patient rooms. You only need to install a single device. So this device right here, it's called our Dual Flex. It's our newest device, and it has a pan tilt zoom camera on the top. But then as you notice on the bottom, it does have a smaller camera that's a fixed view camera, and that runs the AI. Like Lisbeth said, you have to layer an AI in this day and age to make sure that we obviously are optimizing your investment and monitoring these patients, not only from that standpoint of a virtual safety attendant or a virtual nurse, but being able to have AI augment some of that work.
So in terms of what you mostly have out there is the preponderance, this sort of TV integrated, the camera, the one in the middle. Is that what you mostly have out there, or is
Believe it or not, that's our newest device. We released it this year. So we are getting an influx of this device requests for it. But our mobile device is where we started, and that's what we're really strong in. And that's partly because the flexibility of being able to take it in and out of patient rooms. But as organizations are building their virtual strategy, they're moving more to an installed device. And we're seeing more and more of an uptick of this installed device that integrates with both of those devices, installed device, integrate with the patient television.
All right, brilliant. So you have the 3 views here.
Yes.
Should usually be one. What do you do with it?
So what do you do with it? That's a good question. So our core is 2 different applications. One is, like Lisbeth stated, we started in the virtual care space for sitting. And what you can see here is current state, we were a 1:16 model, and the demands are calling for an even larger viewpoint especially when you start to layer in AI. As you can see here, this is a 1:36. So imagine your virtual safety attendant being able to monitor multiple patients at once. But what's unique is we no longer are just focusing on just virtual safety attendants. If you have devices in every room, a nurse manager can see inside of patient rooms. Or if you have remote telemetry, and a lot of times there's a lot of a lack of situational awareness of what's happening in those telemetry rooms. So being able to have your teletech be able to look quickly in a room and see that if they're getting a notification that leads are off, that the PCT is bathing their patient, they don't have to interrupt the caregivers anymore. So they can see and kind of close that loop. I know this.
So the experience. So I'm a virtual nurse sitting at home or in a bunker or wherever I'm seeing into all these different rooms, and these I assume aren't real patients. These are
No, this is just to let you understand. No, this is
okay.
not a real environment. We're not impinging on anybody's privacy. This
All
is
right,
all,
all
yes,
good.
no,
None
no,
of it. None of us are going to go to jail quite yet.
no, no, no. We're not
So
going to display anything from HIPAA perspective.
so something's going on with one of these people, and I'm
Mhm.
looking at it, but also I'm getting an alert.
Yep. So let's give you a little bit clearer view so it's a
Yeah.
little scaled back so you can see. So as you can see, I can see what's happening in all my patient rooms. I do have the ability to go into privacy, which I think is important if a patient, some activities of daily living. But what I think is really key and crucial is that AI component. So right now we do have multiple different AI workflows in place. So we have our falls and elopements. So I know that, again, this isn't a real patient. So it's a real person, but not a real environment. What we want to do is bring the attention to the virtual safety attendant to look in this patient room, especially when you have multiple views happening. So I can see that this yellow is a warning signal that this patient is a fall risk. Bring your attention to this room. We really want to be proactive and talk to that patient and say, hey, Miss Harris, what's going on? It looks like you're trying to get out of bed. Our A model is a little unique that it's more boundary and patient centric as opposed to just boundary centric. So what that means is it's looking at the mobility of the patient. So as their arms are bending, their knees are bending, we're looking at those movements that indicate this patient's trying to get out of bed. It's not just the boundary. So if they're reaching over the bed to grab something on their side table, we get a notification. It's really taken into account both the patient and the boundary. And
I would get an alert as an attending nurse, and then I would literally speak. I can now directly talk to the patient, say, Mrs.
yes.
Harrison, Mrs. Harris in this case.
Yes. And that's what we want to do. We want to
Yeah.
engage the patient. We want to be an extension of the care team. We want to develop a relationship with them and tell them, hey, Miss Harris, I see you're trying to get out of, what's the matter? What can I do for you? I'm going to get your care team member into the room really quickly for you so your needs can be met.
And how does
Ish, go
and
ahead.
how does the care team member get integrated? I saw in one of the other ones the patient's jumping out of bed and is doing jumping jacks, and
Yeah.
comes in to help.
Yep. So what we can do is we can trigger a stat alarm. So as you can see here, if I'm the virtual care team member and Miss Harris is just not listening to me, not responding, it's going to be a little loud for you, Matthew,
Okay.
but I can go ahead and play my alert so I can bring staff to the bedside quickly. And as Lisbeth said, integrations are also key. So when you think about a unit with 30 beds and you have 30 devices, we can also integrate with their nurse call solution to help with wayfinding so that they might hear that tone, but we want to get them to the room as fast as possible. So we want to integrate with their nurse call solution as well. But we talk to them, we engage with the patient. We have clinicians that work with the organizations to build out their program. And one of the key things that we teach is you are an extension of your care team. You're not just eyes in the sky. You are an active participant in this patient's care. So we want you to engage them, talk to them, get to know them, and build a relationship.
And do they have? I think you showed a quick view before. But do they have a view into this that is different? When you showed 36 or whatever it was before, do they have a view into this to make sure that they're getting the alarms quickly and easily? So, I mean, I think that when people look at security guards looking at multiple screens for a long time, they go,
Right.
it's going to glaze over. How do you make sure that the alarm fatigue doesn't happen to the people using your system, as well as we've heard a lot about alarm fatigue?
Sure.
For
That's a great question. We do have analytics, so we have a robust analytics platform, so we can pull a lot of that data. And the way that we train is we don't want them to arbitrarily trigger that alarm without reason to do it. We want it to be active and human validated and a reason for them to come to the room. So that will all live in the analytics. And we're really proud of the fact that one of our training points is that they don't cancel that alarm until a caregiver's in the room. And that way we get true data to show what that response time is. And our national average is about 17 seconds. And it's 19.2 seconds is clinically significant for an adverse event to occur. So we're really proud that they are actively responding to those alerts.
And Elizabeth, just in terms of the way you're organized, is Avasure providing clinical staff as well, or is this all a technology you're providing to their clinical staff that you're training, or how does that tend to play out?
We do not provide clinical staffing, but we have a few great partners that we work with consistently, who we trust and we've had a track record with.
So in other words, I'm a hospital and I want to put this in, but I don't have spare people available to manage it. You can kind of bring those partners along.
Yeah.
How is the integration of that training with the? I don't want to. I know we're going to get back to all the demo here, Dana, in a second.
That's okay.
How is the integration? How's that? Those partners. How do they integrate with the staff? Do they have to? How does a team on the floor on the ward who haven't used something like this before get used to it? How does that work?
That is such a great question. And one of our differentiators is our really unmatched clinical expertise, support, and partnership that we provide. So we have at Avasure, even though we're the technology partners, it's really clinically driven and always has been. So we have clinicians all the way through the process here at Avasure. So on implementation, project management, on Go Live, educators are out there supporting, as well as on the clinical success. And so we've kind of handpicked the partners that we're working with who are also that clinically driven. And so we have that kind of that experience of collaborating. And it's really, as far as the acceptance of the bedside, it's really about that trust building. And just like a real quick story, at our last symposium, one of our partners did virtual nursing from many states away, from Tennessee to New Jersey. So the Tennessee, as you can imagine, salary is lower than the nurses in New Jersey. And there was a nurse there that was resistant initially at the bedside, but she said, for the first time in years and years, I got to slow down and feed a patient, which to me is nurturing and loving them, and also building that therapeutic relationship, while the virtual nurse from the partner took care of some documentation to free me up to do that. So that's how that's built.
That's great. That's a lot of integration is going well and helping both parties. So, Dana, I interrupted you. So head back to where you were going somewhere else.
Perfect segue to talk about virtual nursing. So imagine, if you would, a virtual nurse can be working from anywhere. They can be working from home. They can be working from a hub. We want to make it easy and seamless for them to go ahead and launch a call with that patient. So this is an example how we could launch through an EMR. So I'm working in my EMR vendor, and I can launch that call. And as you hear, we have a virtual, that's equivalent to a virtual door knock, or it's our polite entry. It opens up my audio channel so I can ask the patient if now is a good time. I'm their virtual nurse, and maybe I want to go ahead and review their discharge orders with them. I can launch the camera. Again, this is obviously a loop. It's not a real live patient, but I can go ahead and launch the camera. I can talk to the patient. I can pan, tilt, zoom, do everything. And I think what's important to point out is this patient can also be simultaneously monitored from that continuous perspective. Maybe he's a fall risk, or maybe he's known to be picking at medical devices. I can still beam into the room on the same device using this application while somebody else is monitoring them continuously. So you really do get to maximize your investment by using one device to do both workflows. But in this, I can, like I said, I can still trigger my stat alarm, manipulate my camera. I can share my screen. So if I am sending my patient home, or if, as Lisbeth stated, we're seeing a lot more consults from physicians. If they want to share anything from their PACS system or their lab results, they can certainly share their screen with the patient. It would come up on their television screen or on that mobile device screen. The other component that I think is important to think about is, as we're thinking about virtual care and having people either work from home or remotely, the need to have two workstations or two monitors can be a little cumbersome at home. So what we have is a docking mode. So as you can see, I can still be documenting in my EMR. I still have eyes on the patient. I'm working off of one screen. I am not traversing between two different ones. So I maintain my forward gaze and I talk to my patient, and I can do all of my documentation. The last piece is, patients aren't in this journey alone. They obviously have usually care team members or family members that are a part of their recovery process. We want to make sure that they can be a part of the conversation. So as you can see here, this little button down here, I can add guests to the call. So I can add family members, I can add Clergy is a big one that we're getting a lot lately, and even interpretive services. So if they have a contract with an interpretive services company, we want it going back to that integration component. We can integrate with those, pull them in. And what's nice is all I need when I'm inviting a guest is an email or a cell phone number to pull them in, and they'll get a notification. They don't have to download anything to their device. They can go ahead and join the call without installing an application. It is a one-time link, so once the call is completed, the link is no longer accessible. So it really makes it nice.
Yeah, that's great. So you can I try that for things like discharge instructions, especially if you're picking up with somebody at home. That's fantastic.
Right. Yeah.
So I was interested, and maybe Elizabeth, you can tell me a bit about how this actually works in practice. It's a little bit relevant to the story you just told, but I mean, we heard a lot about nursing and physician burnout from documentation, and how much practical documentation transfer to your service or to people using the Avasure service is there compared to what a nurse has to do? And then what does the nurse on the floor have to do to kind of finalize and sign off? How does that process work a little bit? And give me some estimates about how much work is being shifted from one to another.
I think the bulk of the work happens on the admission process and the discharge process. And so that almost entirely can go to the virtual nurse. The bedside nurse needs to do a physical assessment and document that. They could scribe it, but I'm not seeing a lot of that happening. As far as, having a virtual nurse oversee the, physical assessment, but and that really sets up the patient on the right trajectory for their care, and that decreases the length of stay right there. And then there's education, which happens periodically throughout and on discharge. And just to give you an idea, there was a time and motion study done by one of the health systems of a traditional patient discharge with the nurse at the bedside doing the discharge. That nurse was interrupted 17 times. I believe that, right, Dana? Do you believe that? Easily. Absolutely. So the idea of an uninterrupted virtual nurse able to go through that thoroughly is tremendous. And so I think we have shown like 20-30% decrease in the documentation that bedside nurses need to do.
So a lot of that would be the virtual nurse literally talking directly to the patient and doing doing the documentation.
Yeah, they're practicing nursing.
Yeah,
that is nursing practice.
Absolutely.
Yeah,
I think we are still way too hung up on people being in the same physical place at the same time, for delivering healthcare in this country and in many countries. And I think this is an area where there's a ton of efficiency to be gained, and there are a lot of people who don't want to be standing on their feet all day every day doing the physical work that involves nursing, who you don't want to lose to the workforce
anymore. But they have the heart and they have the experience, and I love that part. I met some virtual nurses, and there were 4 working together in a hub. One of them literally had a cane, and they were like, together we have over 100 years of experience.
Yeah, absolutely.
Who wouldn't have loved to talk to them?
All right, brilliant. And then Dana, before we go, I think you have a cool new thing to show me. So.
I do. I have a virtual care assistant. The other thing I think is important to point out before I go into our virtual care assistant is, speaking of technology and growth and development, we would be remiss not to talk about ambient listening for clinical documentation.
Right.
With Avasure's technology, we have an open architecture, so it does make it easy to layer in some of those best of breed ambient listening for clinical documentation.
How much of that is going on in nursing so far compared to?
That's the challenge. Is it's very prevalent in physician workflows because it's more progress note and more taking unstructured and making it structured, where a lot of the organizations like Abridge and Suki are really looking at the clinical documentation or nursing documentation because we're flow sheet centric. So it's just bridging that movement from that audible discussion with the patient and having it align in the right spaces in the flow sheet. So I'm super excited because I know it's coming, and I know they're working heavily with nursing to make sure that it will be useful and we can get that documentation.
Yeah, I mean, a lot of the reason for that, of course, is physician and clinician burnout and having to do notes and stuff. And look, it's just as bad for nurses. They're burning out just as well.
100% agree.
I hate to say
Yeah.
it, but then the average age of nurses is not getting any younger, and
No.
we need to be very concerned about that as well. But anyway,
Yep.
let's
So
see your
let's show you
virtual
the.
care assistant.
Yes, this is Vicky, our virtual care assistant. She is new to us. Her role is to just bridge that gap, kind of like what you're saying about bridging the gap from the patient to the care team members. So the way Vicky works is she's going to be woken up with a wake word. We're going to say, "Hey, Vicky," and then allows the patient to go ahead and express what they need. So as you can see here, this patient has a severe headache. Vicky's going to be able to kind of triage it, take it using NVIDIA's large language model and being able to apply it to practicality. So what she'll do is she'll listen to the tone, the words that they use, and then it's going to go into our virtual care hub. And with this, it'll allow virtual nurses or unit clerks to triage these patient requests and obviously get the right care team member there at the right time. If it's something that can be addressed by a virtual nurse, they can certainly start a call directly from this, have that encounter with the patient. If it's something that needs somebody at the bedside, they can obviously reach out to the bedside care team members and get them in the room quickly and easily. But they can obviously use this from a task management so they can see what those patient requests are, what their needs are, look at the criticality and address them in a much timelier manner.
So two questions about Vicky.
Oh yeah.
First is, I mean, is she out in real life? Do you have her deployed in hospitals yet?
We are looking for our partners to get her out there because she's brand new to us and we've been playing a lot with her and she needs to get into the hospital setting. We need her to get engaged with patients and see what the patient's response is. We internally think she's great, but we want to get the patient's responses and know what their thoughts are about her.
I mean, you've got then the next, and this I think is very common with anybody. So, I completely nothing. I'm using a system now which has got a pretty good LLM based help function for a bunch of stuff that I need it to do. And every so often you see it's got stuck. It doesn't quite know where I'm going. It's way, way better than the average, click here. You can get the typical chatbot has 5 responses. It's way, way better than that. And it can get to most stuff. But now and again, I go, okay, I need a human, and then they click through, and there's a human. But that interaction between what did the human, the human has to figure out what did it already tell me, what do I already know, and where I am. That's a little bit of a point. So I think that's something that would presumably, I don't know if you've gone down the path of working through the connection between a virtual front end like this, which is AI, and transfer to a human when a human need to. That's an interesting thing now to figure out.
It's exciting times. It really, and the nice thing is it's just really kind of taking some burdens off the bedside care team members, especially if somebody can respond to it virtually instead of having a nurse leave a room and come in to answer something simple like when is lunch or when am I going for a certain test. It's just really going to help kind of augment a lot of that. And I think what's exciting is once we grow and develop, we're going to get into the agentic AI. So we're going to be pulling in EMR information, obviously the patient information, the patient's behaviors, and really kind of bridge it all together and make it, to your point, Matthew, a lot more robust and really fulfill the needs of both the patient and the care team.
Yeah, and I'm sure that's in the Vicky you're going to have, if you haven't already built in sort of the emergency stuff where, oh my god, this is bad.
Gosh, yes,
we
absolutely
need to get some human right in it, which is the same thing that a remote nurse is doing already, right?
Right, exactly.
So that's great. So I think that will actually end up taking a lot of the burden off your remote.
Right.
And then in turn, even more so off the nurses in person. And I'd also assume that a lot of the AI that's currently doing the watching, there could be an interaction between the AI that's doing the watching of the cameras and the video.
Mm-hmm.
And then I suspect, as you go on, I mean, I kind of joke with people. I say, okay, what's the biggest therapy organization in America now? And the answer is ChatGPT, right? And I suspect that as more and more people get used to this kind of avatar and a lot of people now are talking to ChatGPT and other LLMs for a bunch of random stuff, and you're sitting in a hospital room, you're kind of on your own.
Yes.
You can imagine this kind of thing is going to pick up, and Vicky's going to have to get smarter and smarter about a bunch of stuff. Probably not including anything to do with healthcare, right? I want to talk about the football.
Yes, about football. Yeah, we did ask her who's going to win the Super Bowl, and she claims the Buffalo Bills are going to win the Super Bowl. So
she's not entirely dumb, given how they've been doing. If they can just get past the Chiefs one of these years.
Yes, exactly.
Fantastic. That's brilliant. Well, look, so you've got really an amazing panoply of stuff that you guys have built out over the years, and obviously with the introduction of AI and LLMs, there's even more that this can go to. So, Elizabeth, give me a sort of state of the play. I think you mentioned earlier you guys were in 1,200 facilities. Give me some numbers about how many facilities you're in and how many cameras and how many rooms you're deployed in. Just give me some idea of how big you guys are.
Yeah, and I think that's a very pertinent question because this is what health system leaders are concerned about. They want to make sure they partner with someone that's going to be there 3, 5, 10 years down the line, because this is a long-term partnership like we spoke about. So we are in 1,200 hospitals across, I think, every state in the US and Canada, and with the strong financial performance that we've had since I've been here over 11 years. And what that means is we can reinvest in the R&D.
Can you name some of your partners? Which are some of the bigger hospital systems you're working with?
Oh, yeah. And I think we have it scrolling on our website. And those are those that have allowed us the permission to share. But I think we talk a lot, and we've had some great presentations recently from Hackensack Meridian Hospital, and UC Health is a good one, Baptist Jacksonville, Trinity, all of Providence, all of Ascension. And yeah, many of that I could
and
go
when you take this into hospitals, how long does it take before they, and maybe this happened a long time ago, how long does it take before we hear a lot about hospitals, well, this sounds cool, let's pilot in one wing or one floor or just one facility, and then we have 25 or 50 hospitals in our chain. How long does it take to get from being that sort of we'll experiment to saying, oh, this makes sense to do system wide? How long is that progression usually?
I think that is changing rapidly because of the big beautiful bill and this impending crisis that's coming, and even tighter margins in 2027. Here in 2025, people are no longer dabbling. They don't have the time for that. They need the efficiency of virtual care. And so we're seeing less and less of that. Let's pilot and see what happens. So and I know that our time to ROI is very short, like it can be within a quarter, especially if you start with virtual sitting, because that's so easy. So in the past, I think there were dabblers, even 2023, 2024, but not now.
So things are moving on. And then you mentioned ROI. So how much does it cost to install, and what is the ROI? You said the payoff super quick. Give me a sense about what people are saving, where they're saving, and
so on the virtual nursing side or virtual sitting side, for example, it costs about, with the technology and the staffing, which is a virtual sitter, costs about $3 an hour to take care of a patient, keep them safe, versus the $25 an hour if you had an in-person. So that's right there. That's and the hospitals have 30, 40 sitters at any given time easily. So that gives you an idea of why it's so quick to an ROI. And on that, you can build the others.
Very good. And then last question. You guys got a pretty big investment from, well, actually it was unnamed, but an investment from Goldman Sachs a while back. Give me a sense of the scale of the company, where you're on revenue, and then the question everyone's going to want to know is what happens next? Do you think you grow further? Do you think you IPO? Do you where are you in the sort of the world? As I've heard rumors that if investors give companies money, they eventually want it back. So.
Release when that happened, and that was Goldman Sachs and Heritage, which is another private equity firm that really specializes in healthcare. And so together they just brought us tremendous amount of expertise in helping us take it to the next level, which is really exciting. And I don't have a crystal ball of what will happen next, but I'm excited to be a part of it. That's for sure.
Oh, give me. Do you have a sense? How many people are there in the company now?
230.
Okay, and how many were there when you got there?
There were probably 40.
Okay, so you've seen pretty significant growth for the last decade.
Yeah. And there were about 30 hospitals when I came, and this was in 2014, and now they're 1,200. So, I mean, I pinched myself to be part of something like this, from early startup to something, really that's become the standard of care.
Fantastic. Well, it's obviously a fantastic technology wave to be riding, and it's and as we said, it's also a change in how actually nursing is done, and an improvement in how nursing is done. So I think that to me is the important thing, is that you're both sort of using technology to improve the patient experience, improve the nursing and the care experience for everybody. And that's what we need to be doing more of in healthcare. So congrats for that.
Yeah.
Fantastic. All right. Well, this is Matthew Hall. I've been talking with Dana Peco and Lisbeth Vortruba. I'll get your name right one day. Who are respectively the AVP of Clinical Informatics and the Chief Clinical Officer at Avasure, rhymes with Lavasure, which, as you hear, is one of the leaders in virtual and a lot more staffing, help, care. I don't even know what to call the category, but improving nursing using technology. How about that?
Thank you.
Thanks. Great to talk to both of you.